Well, good morning and welcome to Sunday Morning Coffee with Dr. Childress here. So, today I'm going to be talking about onboarding new clients. I've just finished off the first week of the month general public consults with parents and the trauma pathology that is in the family courts. And this is a trauma pathology in the family courts, as well as many of you may well recognize. It's child abuse and spousal abuse. So we're in trauma world. And unfortunately, the mental health professionals working in the family courts don't quite understand where they are. So today in this, because I've got a new couple of new clients coming on, consulting clients, and we spent a lot of time talking about the overall scope of their situation. But one of the primary issues they're facing, all of you are facing, and I've got other clients currently that are encountering the same issue, is how do you find the mental health professional where you are? The local mental health professional. It's very nice to have me on board, but we need a family therapist for you to actually fix things, because all the court custody stuff can sort of be resolved, but we still need a treatment. We still need to fix and rebond with the kid and get everything settled. So how do we get you a mental health professional where you are? And then I can consult with them, and then we can improve the quality. We can get the proper treatment in and fix everything for the child, for you, for the entire family. So because I have a couple of new clients coming on, I thought, and with the same issue of locating somebody, I thought I would do my Sunday coffee today, talking about onboarding them and giving them information as we begin our work together. So this may be broader, more broadly of interest to other parents as well. So to begin with, let's just take a look at what your situation is. So this is a visual representation of where you are. You are being contained within a subspecialty field called forensic psychology in the family courts. And it's a barrier that prevents you to getting out to the other real psychology people. So things like ADHD, autism, depression, anxiety, those are all handled within normal mental health. And so you get competent mental health people in each of those fields, and they abide by the APA ethics code. You've been isolated into this family court zone, and you don't get quality mental health services. In fact, you get the lowest quality imaginable. They are unethical, incompetent, and they're apathetic. They simply don't care. And they have no idea what they're doing. And they wind up destroying things. And that's the forensic custody evaluators. So you do not want a forensic custody evaluation. $10,000 to $20,000, 6 to 9 months, doesn't give a diagnosis, kind of a waste of time and money. And not only a waste, it basically pours cement into any treatment efforts for 6 to 9 months, 9 months, while they do their leisurely interviews and custody evaluation. So if you get one, or if you have to for some reason, we can work with that, and I can provide a review through AI and stuff of that evaluation. But we still need the treatment provider. Who's going to do the treatment? And you have nothing, and you're being isolated from the rest of psychology. So we basically have two choices at this point, given the nature of the dysfunctional mental health system. Our first option is to reform a forensic custody evaluator, because they work in the family courts. They're the ones who should be providing the diagnosis and treatment. But instead, they've gone off and doing the forensic custody evaluations. So they're not providing a responsive to mental health service to the needs of the children and parents and courts. They're just doing what they want to do, which is a custody evaluation. And so if we can grab one of those, or if you can find one of those to reform into diagnosis and treatment, then we can pair them with me and we can move into diagnosis and treatment. The problem or the barrier to that is that we're starting with an incompetent and unethical psychologist. So I'm not really happy about, that they're unethical and incompetent to begin with. I'd rather have an ethical and competent or somebody who cares. The second option, though, is to recruit from outside and to recruit back into the family courts to work with you. And there's basically two domains here because we have two variants of the pathology. If you're a mom, you're likely in the narcissistic dad pattern that has a higher spousal abuse feel to it. And if you're a dad, you're most likely in the borderline mom pattern that's going to have higher anxiety and false allegations to it. And so the therapists who work with the narcissistic and borderline pathology, they are in the domain for the narcissistic pathology. They're in the domain of spousal abuse, intimate partner violence. So if you're a normal range mom with a narcissistic dad, you want to get over to the spousal abuse therapists, intimate partner violence, and then you pair me with one of those. The advantage to the narcissist or to the IPV therapists, the spousal abuse therapists, is that they're working trauma. They work spousal abuse. So they're a little tougher. They're familiar with the protective response, and they're not as afraid of the court system. And so that's an advantage to them. And they will recognize the narcissistic personality pathology of the ex. If you're a dad, though, you got a borderline. So they're not attuned to the borderline. They're attuned to the narcissist. But they do have that protective strength. And so, whatever you brought me on as a consultant, so I'm going to be working with whoever you can locate. So locate the best you can, locate somebody you feel good about, locate somebody who's cooperative and willing to take the task. The IPV spousal abuse therapists might cross the barrier into the family courts because of their protective understanding. For the other variant, for the dads, you'll want to get out to the borderline therapists, and those are the dialectic behavior therapists, DBT. The issue with them, though, is they work with the actual borderline, not with the family, and so they're not really aware of family dynamic issues. But they will recognize the borderline pathology and potentially the persecutory delusion, because that's highly associated with the borderline spectrum kind of pathology. And they'll have a lot of the skill sets they'll know that can help with the child and can help with you and cope and help with the mom in coping with the various features and vulnerabilities of that personality type. And the issue with them, for you, the barrier is they won't want to work in the family courts. They won't want to work with either families or in the courts. And so that's going to be a barrier to getting them back in. So just to take a look a little bit about our options. The second option, you would want to be going out, locating a therapist who is capable, competent, cares, ethical, and then trying to get them to work with your family. Now, when you do that, when you approach them out and they're going to be scared of the family courts, and rightly so. And that's not a domain they feel comfortable in. Then they may say, no, and they'll refer you back to the forensic psychologists who only do a custody evaluation. So that's going to be a bit of a problem of getting them back in. Spousal abuse therapists may be a little bit more cooperative in that. So when you're reaching out to these outside therapists, minimize the level of the court custody conflict and frame things in a way that is consistent with their understanding. So if you're a dad and you're looking for a DBT therapist, present the problem as therapy related to a borderline spectrum mom. Now, when talking about borderline or narcissistic, but particularly around borderline. The label is problematic. Okay, it captures a lot of the features, but really what we're looking at is unresolved trauma. And so as we move from diagnostic concerns over to treatment, we're really going to be shifting over to unresolved trauma with the mother in this case. And so to frame it up that way as early as possible, I think is helpful. But if you're working directly with a DBT therapist, that's what they're trained to do, is borderline. And they use DBT for a lot of things in training, for substance abuse and everything. You want to find the direct treatment of borderline personality with dialectic behavior therapy. Typically, it's like using coaches, and it's a team kind of based kind of model. Therapist and a coach, and they have a curriculum and stuff. If you can find a good dialectic behavior therapist. The spousal abuse therapists, if you're a mom going out to them, that's going to be a little bit better or easier to frame that up as a spousal abuse using the child as a weapon. And so if you minimize the court again, and you've brought on a consultant. So if you brought me on, I'm your consultant. You have me in your little stable of people that I can consult with any of the mental health professionals around you. And that's what we're looking to do. We're looking to set you up and your consultant up with somebody there who is open to getting information, then we can fix the problem, the diagnosis and the treatment, if we can find somebody to pair me with. And so that's what you're kind of looking for. And if you get an IPV therapist, even if you're a dad and get an IP, because it's spousal abuse of you using the kid as a weapon by a borderline spectrum mom. So if you frame it up as that spousal abuse issue using the kid as a weapon, and then when weaponizing the kid, it becomes child abuse for the child, because you're just creating such significant pathology in the child. The spousal abuse therapist, IPV therapist, may have a better time on grasping that and understanding that and going, okay, I get it. And that's probably more true for the normal range moms and narcissistic dads, because that's a gender-based pattern we kind of have. Whereas if you're a dad, you'll have to cross that gender bias, that you are a spousal abuse victim. And so that's the issues around the recruiting from the outside. You're going to have to get them to cross that barrier, that boundary of the forensic custody or forensic psychology in the family courts. Now, the other option is to reform a custody evaluator. And so what you're looking for there, because they have the advantage that they already work in the family courts, and they are the ones that should be providing the diagnosis and treatment. But they're not, because they want to make lots of money and they don't want to do diagnosis and treatment. They want to just do their custody evaluations. So the mental health system is broken. It's not responsive to your needs or the needs of the court. It's just responsive to their needs for money and comfort. But however, that field is changing. The era of forensic custody evaluations is coming to a close, because they are awful and ineffective and dangerous and harmful and bad things. So they're going to be going away. And so you may find that some of these custody evaluators may like the opportunity to shift into diagnosis and treatment. And oh my goodness, you're giving them Dr. Childress as your consultant. And so if they're willing to shift back into actual clinical psychology, diagnosis and treatment, then that's an option for you. And then you pair them with me, and you've got all my web resources around it, that if they are motivated, and that's the thing, if they are motivated, there's all the information they need. The problem is you can't find a forensic psychologist who is motivated to learn anything, or to be competent, or to be ethical. And so if you don't have the motivation, there's no working with them. That's just the way of things. Now, what should be the situation is that the mental health system around you should be responsive to your needs. You shouldn't have to find somebody. We should be giving you people who know what's happening and can diagnose and treat the problem and fix it. But we're not doing that, the mental health system. And so as a result, you have to cobble together your treatment that's actually not available because the forensic psychologists are withholding diagnosis and treatment from you in order to enrich themselves and for their own comfort and career status kind of level. So, but that's a changing system and that will be emerging over time, but it doesn't help you now. And so that's where, if you can be part of that change as it starts, as these forensic custody evaluations begin to dissolve and we can get some actual responsive therapists, then we can move into a system-wide solution on the situation. So here's the fundamental thing we're trying to reach, which is consultation. I have all the knowledge. I can fix it. I can diagnose it. I can do it. We just have to get my knowledge to the local area professional who's motivated to acquire knowledge and figure out what to do and solve the problem. And so this is from Improving Diagnosis in Healthcare. And I can get you the quotes, and it's up on the web. It's a big paper by the National Academies of Sciences. And for improving diagnosis, this is what they say about consultation. Clinicians may refer to or consult with other clinicians, formally or informally, to seek additional expertise about a patient's health problem. The consult may help to confirm or reject the working diagnosis, or may provide information on potential treatment options. Clinicians can also recommend that their patients seek out a second opinion from another clinician to verify their impressions of an uncertain diagnosis, or if they believe that this would be helpful to the patient. So just think about standard healthcare. If you go in for a medical problem, they're always referring you out to specialists and things because that's what healthcare does. Consultation improves the quality of health services. That's and that's why doctors do it all the time. But in the family courts, they get very litigious. And so each party is trying to say, no, and try to isolate, and so you only get one. You don't get to talk with, and that's a real problem. The legal system is destroying that consultation process that the healthcare system benefits from. So we'll talk about a solution to that in a second. But what we're looking to get this out of the legal system for a variety of reasons. Too expensive, it's a wrong system, it delays, it's a problem. We need to get it over to the healthcare system. This isn't a custody decision. Custody is easy, 50-50 and, or every other weekend or distance, school year vacation. But there's only really three models. The problem is the child's pathology. The child's rejecting and saying, oh, that's a treatment issue. We need to get it over to healthcare, diagnosis and treatment. And in healthcare, we consult. So what you've done is you come out and located me, my expertise, attachment, delusional thought disorders, family courts, and you brought me in as your consultant. So now I'm your mental health wrangler. Okay, anything mental health, I'm going to be putting in information, giving it to you, giving it to your attorney, and giving it to the other professionals. And so I'm available to you to offer to them or to suggest they consult with me. They should be suggesting that you consult with me. They should be doing it on their own, pursuant to Standard 2.01 on boundaries of competence. So ethically, they should be consulting. They're just not. So that's a problem right there. But you can encourage them and ask them because of the uncertain diagnosis in the situation. Talk to Dr. Childress about that. Before leaving that too, I just want to point out that that the consultation can confirm or reject a working diagnosis or information on potential treatment options. And so if I'm through telehealth, I'm able to be in any office, anywhere, anytime. And so, with the proper permissions, court authority, in this case, I can be sitting in the therapy session and watching. And so I'm available for consultation on this. The and the other thing I want to point out about that, in the first opening, it says clinicians may refer or consult with other clinicians formally or informally. So, if it's a formal consultation, then we need maybe court authority on that. We'll talk about in a second. But informally, if I don't know who their client is, there's no breach of confidentiality. And so they're fully capable of just reaching out to me and talking about their case, which happens to be you. As long as I don't know it's you, that's fine. And I can consult with the GALs or minors councils or anybody you have around you. I'm working in the service of you. I'm working in the services of the child and the court. There's my two clients, but that serves your interests, which is why you brought me on board. So here. We need to understand this clearly. The patient should never need to explain the pathology to the doctor. Oh my gosh, if the patient's explaining the pathology to the doctor, that is a seriously bad situation. If anyone needs to explain the pathology to the doctor, it should be another doctor. Okay, so that's why you brought me on board. I'm your other doctor. I'm available to explain the pathology to them. However, you're in the situation of having to recruit these people to help work with you and work with your child and family, which means you're going to be in a position of explaining the pathology to the doctors. And that was the question of how do I frame this for the doctors to understand? And so when doing that, you want to stay in your role as a parent. So you don't want to get in too technical and things. And the other feature, unfortunately, you kind of have to manipulate them a little bit. If you become assertive and start to say it's a this or and that's anxiety, and you go it's a mom and she's doing stuff and you're trying to prove reality to them that this is what's going on and it's not you who's causing it, it's the mom, you're gonna get pushback because assertion will get pushback. That's the angry channel of affective signaling. It's a power assertion in voice, like what I'm doing now. So what you want to do is smile. Okay, because when you smile, you drop a little happy chemical into your brain. Okay, and happy is the social bonding emotion. Now, notice I'm keeping a little smile right here, and you can hear the change in my voice. From before, I was this way, and now I'm just a little softer. And so it's an emotional signal of social bonding. And so just smile. Okay, they drop a little happy chemical in there. And now you can be assertive and say, I'm really worried about mom. She's doing all this stuff and she's distorting the kid in. And it's, oh my God. And then you also want to signal your sadness and loss because that's the other social emotion that draws nurture. So, oh my God, I just miss my kids so much. It's like they mean the world to me. And mom is just like doing this stuff. And so you get the social bonding, emotional signaling, you get the sad draws nurture emotional signaling, and then the content of your words can be explaining the pathology. Thought disorder, the delusion is a type of thought disorder. There's conceptual disorganization and tangentiality. There's other types of thought disorder, but a particular type is a fixed and false belief maintained despite contrary evidence. That's a delusion. This type is a persecutory type, the most common type, where they're being malevolently treated in some way, their victimization. And so you can use the word delusion, but that gets a little specific for the psychologists, and they may say, you're using technical words. It's a thought disorder. Now, the assessment for a thought disorder, for a delusional thought disorder, is called a mental status exam of thought and perception. Thought and perception. And it's a very linear type of examination that pops the delusion out during the session. And so if you use the term thought and perception, that's kind of like a little code word. So what you want to talk about, going back to you know, the parent's personality pathology as being unresolved trauma, the way you want to frame this up is you're worried about the other parent's unresolved trauma that has distorted their thinking and perception. Unresolved trauma distorting thinking and perception. And that's your kind of framing for personality disorder that is creating a persecutory delusion. And it'll soften it up a little bit. And then you want to de-emphasize the custody battle and move it more over to the attachment pathology. Don't use made-up pathology labels. We need to get attachment pathology is that rejection. We're worried about child abuse, and so we need to start saying child abuse, spousal abuse. You can put that on the table. I will put that on the table for you, the spousal abuse one, so you don't need to worry so much about that. But the child psychological abuse that's going on. Oh my gosh, they've lost their loving relationship with a parent. You love them so much. What's the problem with getting love to the child? Why is a child rejecting love? I mean, that's like, what? And so the child and the other parent are going to have a narrative that you deserve to be rejected. Reframe it. That you want to love the child and the child's not accepting love. How odd is that? Very odd. And it's an attachment pathology, a factitious attachment pathology. But what you're looking for to do is to locate a mental health professional who may not understand everything. They won't understand everything, but who's willing to work, who understands enough that they're willing to work with you and your expert consultant on solving it. And it can be a forensic custody evaluator who's making a shift, or it can be a spousal abuse or borderline therapist who's helping you with the treatment of your family. Excuse me. So now here's the other valuable domain, which is in consultation, because of the courts and everybody, they don't want to talk with me directly, because whatever reason is. I've got all the information up online. Okay, so they don't need to talk with me. They just need to watch the videos and they'll get the information. And so I have a whole series, the diagnosis series. The easiest way to get to my videos of selected videos is through my consulting website. You go to my consulting website, there's a YouTube button, you go to the YouTube button, and there's all my videos, some of the selected out Sunday coffees, one on the contingent visitation schedule. But the top one that it shows up on is the diagnostic series, and I have a bunch of those. And so those are the nice stop shopping for all of my videos. But if you're making referrals or recommending, you may just want to pull out these four, and make a recommendation on YouTube or through YouTube, or my YouTube channel, individual videos. And the four that are of most value in my view, the top two, I would start with the attachment pathology. I think that's the most valuable one because it provides an understanding for the child abuse. This is child abuse one way or the other. That's the only thing that causes a symptom of a child seeking to flee a parent. A child rejecting a parent, that's a disorganized attachment. That's either child abuse or psychotic range parenting. That's abusive or psychotic range parenting. That's the only thing that causes a severe attachment pathology. So that segment or that video is valuable and foundational in my view. Then the other one that's valuable is the diagnosing persecutory delusions, because I walk them through that mental status exam of thought and perception. How do you diagnose a delusional thought disorder? Well, there's the video on how to do that. In addition, the two sort of supporting ones that I think are valuable is the diagnosing child abuse in the family courts. Because again, we got a child rejecting a parent, that's going to be child abuse by one parent or the other. And so that video talks about the path A, path B. Path A is that the targeted parent is abusing the child, and so it's an authentic child protective response to an abusive parent. Path B is that the allied parent is creating a persecutory delusion and factitious false attachment pathology in the child, psychological child abuse. So it's a path A, path B, differential diagnosis, and that talks about that. Then the other valuable one is the one just on overall DSM-5 diagnosis of family court pathology. We need to start using the DSM. Please, everybody. And there's a variety of reasons for that. One of the foundational reasons is it provides clarity from doctor to doctor about what's going on. So as your consultant, I'm going to want to know, is there a persecutory delusion in that parent? And so the mental health professional needs to answer that question for me. DSM-5 diagnosis. And if not, why not? Because it seems to meet all the criteria for a delusional disorder. So why isn't it a delusional thought disorder? Why isn't this child psychological abuse destroying a child's attachment bond? Why isn't this spousal abuse using the child as a weapon? I want them to sort of support their diagnosis or their absence of a diagnosis. That's what all the second opinion consultation among doctors is designed to do, elevate the quality. And if we're talking about child abuse, we really should be getting second opinion eyes on this, especially if they're not diagnosing the child abuse. Why not? So you can provide these videos to people here, to your professionals, your GALs, and everybody. And you have available the human that did this if anybody wants to talk with me about the specifics of their matter, any professional. So now, arranging in-person consultation. You already met my case manager. When you scheduled the appointment, she reached out to you and gave you the forms and stuff. And so you've got her email, and you don't have to wait for the first week of the month. You're on board. You've got Dr. Childress as your consultant. So you can give the GAL, the therapist, any prospective therapist, you can just give them the email of my case manager and get them to schedule an appointment with me onto my calendar. So that's pretty easy. If they're willing, I'm willing. In terms of what we're going to be one potential solution, my recommended solution, we need to get this to treatment. The focus of the court is the wrong endpoint. The court's going to be focused on its custody decision. No. We need to land on treatment, fixing everything. Even after the custody, whatever it is, we need to fix things. And so the beginning of that process is to get consultation in. Because any diagnosis returned to the legal system is going to be a disputed diagnosis because it's a litigious system. It's an adversarial system. One party or the other is going to say that's an inaccurate diagnosis. The appellate system for diagnoses in healthcare is a second opinion. So let's get that right at the start. But now it's adversarial. Who's the second? Let each parent appoint their own consultant. So now we got 3 doctors, like a 3-judge appellate panel, 3 doctors, one conducting the assessment in their office, and each party appoints a second opinion through telehealth. You'll be appointing me if I'm your consultant. And so I'll be in there, and what they do is they log on to my office, my DoxyMe office, spin the monitor around, and there I am. And then if the other parent points their consultant, they log into my DoxyMe office, and then we got to the 2 doctors sitting in telehealth and the person conducting the assessment. We meet before, we meet after, we talk about the case, and we offer the court our joint opinion, maybe some dissent, maybe some support, but then the court can make its decisions off of that. Okay, that's how we need to stop the fighting around these children and move it out of the courts and into effective treatment. That's our goal. Get it into effective treatment, out of the courts and into treatment. Let's get consultants on this, get the doctors coming up with what the diagnosis is. Diagnosis guides treatment. You're concerned, and your doctor, your consultant is concerned as child abuse, delusional thought disorder by the other parent. Their consultant is concerned you're abusing the child. Good luck with that, and we need to get those answers back to the court. And if there's a discrepant opinion, it's going to show up. Two the doctors are going to be supported diagnosis, and one's not going to be supported. So it becomes pretty clear if they try to put in a less qualified professional, an advocate of something. So this is my recommended model. So each litigant appoints a second opinion. We go into clinical diagnostic assessment that then leads to the court's decisions and ultimately an effective treatment plan. Now, if we turn this on its side, this is the one I like because it goes out and lands on treatment. So it's the same one, except turns on its side and extended a little bit. So you see each litigant parent appoints a second opinion, gets a diagnostic assessment, goes back and feeds the court's decision, but also guides the treatment going forward. And notice those two consultants can continue as consultants on the treatment. And so that will improve the quality of your treatment as well. So this model right here is where we want to shoot for if we can get it, but maybe not. Maybe we'll get something close or something. The fundamental issue is you're going to need a family therapist on this. That's just a fact. Because you got a very fragmented family, you're going to need to repair the attachment bond between the parent and the child. Power of Discord, Tronic and Gold. Okay, there's your book on repair of relationships. So we'll be focused on Tronic, top tier attachment person, Power of Discord. We always repair. So we're going to want to fix that relationship. And I can do that. I know how to do that. I can help the therapist do that. We just need a contact point of a therapist who's willing to consult, and then the proper court permissions to get this family therapy structure that's necessary. The court doesn't need advice on what the custody schedule should be. The court needs a solution to the family pathology and the child's attachment problems, whatever it is. If the targeted parent's causing it, then we'll put it on a treatment plan and fix it. If live parent, put it on a treatment plan and fix it. I just need to know which parent is abusing the child, because if I've got a child rejecting a parent, one parent or the other is abusing the child. The final thing I want to touch base on coming into my practice is that I've incorporated AI into the practice because it's great. It's neutral. It's a high-level analysis, and it's APA. It's APA compliant. With the APA released an update to their ethics code on the use of AI in health services psychology. And my work with the AI is fully compliant with all those ethical requirements. And the AI I use, ChatGPT-5, is ethically contained. So in the memory slots, I say, Max, you're contained within the APA ethics code 2.04, 9.01, 2.01, 3.04, and it says, okay. And I say, remember that. And it says, okay. And so it's ethically contained, but it's also trained by me. So we've had some training where I said, we're not looking at ADHD or autism. We're in the family courts. We're looking at this possible delusional thought disorder, attachment pathology. And it goes, oh, okay, I understand where we are. So it's trained by me for the scope of the pathology we're looking at. And then I supervise it. And so it's great for document review is what I rely on it for. So any of the reports that you get in, emails between you and the GAL, or, reports you've had from other people, therapist provider reports, treatment notes, anything, your emails with the other parent, anything that is documented, the AI can take a look at it. And so we'll get a little chat dialogue kind of formed up with you. And then once we have the basic set of information there, then you get more information in. We just put it in the same chat, and it begins. And when if I do ever do any report, the report will be written by me on things, but I will be relying on the AI dialogue and that I had, the analysis. And so I provide that chat analysis to whoever, so you can actually look at the AI and its reasoning about the situation. So you can provide that to the court, but you can also provide it to the involved mental health people, to the GAL, to the Minors Council. Not only do we have the whole chat dialogue, if we can work together to pull out segments of it, and if you want to focus on particular issues, we can do that. So I work with AI because it's extraordinarily helpful. It's neutral and it's a high quality analysis. And so my location for that domain, the all AI psychology, is Substack. So I recommend that you just become aware of a few of the essays up there. So I have an essay up on the American Psychological Association guidelines and a couple of additional essays on use of AI in the family courts. And those will be emerging over time as well. So for that, you go over to my Substack. So with that, I'm going to be wrapping up my Sunday talk here. If coming on as my client in this situation, I have two clients when I'm brought into a matter. The child is always a client. In any family situation, I work for the child's best interests. And my obligation to the child is to ensure that the child has an accurate diagnosis of whatever the problem is and an effective treatment plan that fixes the problem. That's what I'm here for. When the court's involved, I get a second client. That's the court. And my obligation to the court is that the child gets an accurate diagnosis and an effective treatment plan to guide the court's decision making. Okay, so my obligations are the same: an accurate diagnosis and effective treatment plan. But I'm in the service of the court and I'm in the service of the child. So's the AI, and the AI knows that. Now you are the conduit that's bringing me into this matter, because that's your desire to get the child taken care of and to resolve the court's decision making, get accurate and productive decision making out of the court. So if I do my job relative to them, that makes you happy. It makes you happy, it makes your attorney happy. And so that's sort of the client structure. But you're the conduit to everything. You're putting together a treatment team. Treatment team is going to include the family therapist. It's got me as a consultant. Might have a GAL or might have, your attorney on situations. But most likely, we want to get it out of the family courts. There's probably not a real need for individual therapists, so we'll take a look at that, and because they can become problematic. We need a family therapist who can kind of help cohere this family. Everybody's fragmenting, and if we have a bunch of therapists that continues to fragment things, we need to pull it in based on an accurate diagnosis and effective treatment plan. What do we do about the situation? I don't know. What's the diagnosis? You tell me the diagnosis, I'll tell you what to do about it. Is it a persecutory delusion? Is it child psychological abuse? That's what I'm going to want to know from a local mental health professional. Who? Reform a forensic custody evaluator, get a dialectic behavior therapist, get an IPV therapist, get the best you can, get whoever you can. You're going to pair them with me, and then we'll see about improving whatever domains of knowledge they need improved. My final thought, because this is a delusional thought disorder and a factitious disorder imposed on another, those are two major psychiatric disorders. Getting a psychiatric evaluation, particularly around the persecutory delusion, because it's a mental status exam, it is valid. So if you're in a location and you go to one of your top hospital-like locations, medical centers, and you get an assessment of each parent for possible thought disorder, looking at a possible persecutory delusion in one parent or possible spousal abusive range parenting in the other, and you take a look at the situation and see if we got a persecutory thought disorder from a psychiatric assessment. That's a viable diagnostic route. The issue is that psychiatrist is probably not going to be continuing on with the treatment. So we still need somebody who's going to do the treatment, who's going to be the family therapist, who's going to be organizing this family and treating the fragmentation. Now they can be informed with that diagnosis, and that's a start. We got an accurate diagnosis, so now we can come up with the treatment plan. But who's that person? So going forward, I'm here, I'm available, and you know where to reach me. And we'll talk later. So good luck, everybody, and I'm going to head off to my Sunday now.